I'm Dr. Jason Bekta, and this is Out of the Basement, a podcast focused in general on practical radiation medicine. So today I decided that I want to hit a hornet's nest with a baseball bat because these are things I find fun. And I wanted to explore how doctors get paid. More of that I have come to really appreciate and realize that there is no formal business or financial curriculum in med school, at least when I went to med school, which I usually say was not that long ago, but I did start medical school 14 years ago, 15 years ago. Anyway, maybe you guys have changed it. Somehow I doubt it. But so there's no training for me formally in med school or residency. And from time to time, my patients and I will talk about this, and that they will be concerned about how much a treatment that I'm going to give, or a treatment that I have recommended, how much that will cost them, how much that's going to cost their insurance, how much that's going to cost out of pocket. And honestly, I don't know. I can have a general idea, but if you take 30 patients with prostate cancer and put them back to back in my clinic, I can't tell you with certainty what any of them are going to pay. And exploring what that is, essentially now, even though I am currently, for the next few weeks at least, in a true private practice, meaning that we provide professional services to a hospital on a contract, and the hospital receives the technical reimbursement and my group receives the professional reimbursement, so the old school style of practicing medicine. Even with that arrangement, it's a black box in a sense that I can't control what the hospital charges the patients or where that money goes, or I can't change the price of a treatment personally, any of those things, even though I'm the one sitting in the room with the patient is the one receiving the treatment, and both of us have lost any sort of control over that quote unquote transaction. And I think about this a lot and think about, how did this come to be? How did we get here? And so one of the things I'd like to do over several episodes, just because obviously this is a very big topic, is explore the business of medicine. Not in a sort of classic sense, because the one avenue you usually see this is around the concept of financial toxicity, and that you have people pulling databases, either CMS databases or some other database, and doing classic sort of academic analysis on it and arriving at some sort of conclusion for a poster presentation or a paper or anything that we see. But just the actual nuts and bolts, like how this affects me, you, if you've been a physician or someone in medicine listen to this, and any of that, no one really talks about that, at least not much, or at least not in a way that is accessible if you don't go looking for it yourself. We'll see. But really, I know this is a very touchy subject, and I don't really know why I like to hit hornets' nest with baseball bats, yet just the way I am. This also really got started when I started looking for a job during my job search a couple of years ago, the start of the COVID pandemic now. I came across articles talking about in January 2022, based on a survey, that 74% of physicians are now employed by either a hospital or a health system or a corporate entity. And it's never been in all of history in America, which in the world, I guess, is not that long of a history, but at least in our history, that has never been the case. So 74% of physicians are employed as of 2022. And then if you look over about a 1-year span from 2019 to the end of 2020, about 21,000 private practices were bought by some sort of entity as well. And this is part of a larger trend, usually, and I've tweeted about this occasionally, but usually things like the academic health, where they will buy up formerly independent practices, and you just have this giant conglomerate, this Borg of entities, which is a dominant trend now in America, and it's not exactly going to change. Because of that, in this, with 74% of doctors being employed and just tens of thousands of independent practices closing up shop or selling out, they've really removed us from the equation by us, the doctors, and that there is, at least when I was in school, before I even went to med school, when I was in residency, to this day, there is this cultural opinion, I want to say implicit, but even frankly explicit as well, that doctors thinking about the business of medicine is greedy or immoral. And again, not talking about the database sort of analyses, but the day-to-day, how it would affect me and you in our paycheck and how we pay our rents or mortgages or those sorts of things, and how our direct actions, what they cost the patient and the system. And but if you take an interest in that, there's a bias away from that, or that it's not good. By doing this, or by acquiescing to this, we've basically allowed non-clinical actors to command American healthcare. So the MBAs coming out of B school who have never had any sort of medical training, because we have done this to ourselves, or allowed it to be done, because there's rules in place about what physicians can or cannot own or do or refer, or things like Stark Law, all these things. Really, we've established a system where people who don't have medical training or experience are the ones who call the shots. But ignoring the financial side of medicine does not mean that we have taken an ethical high road. It means that we have given up control of an essential component of providing care, where we can feel good and safe and feel like we really have earned the pat on the back of, look at how ethically moral, strong, good, whatever I am, because I don't talk about this or don't think about this, when really you should. Because the fact that I can't change how much one of my treatments costs one of my patients, and is all that really needs to be said about how important this is. And that was the drive for this, is that I was actually quite frankly shocked about the 74%. But so starting with, try to decide, I have a couple of drafts of these, trying to figure out where to start. So I figured I'd start with everyone's favorite, the RVU. What is the RVU, or the relative value unit? Because I'm certainly in residency, you hear about RVUs all the time, because in residency, at least in radiation oncology, radiation medicine, we are pretty much all in large academic health systems. So the RVU is the central component of our experience, but I don't remember being sat down and told what this was. So RVU, again, is a relative value unit, and it's how Medicare pays us, because we don't produce a widget. We don't produce a tangible item. And for any service like this, kind of these thought services or whatnot, even though we do a lot of procedure-based stuff, but what is the value of that? We don't bill by the hour like lawyers do. And again, we don't have a product to sell, a physical good. And when Medicare was invented, when it came out in the 60s, the government, there was a different way it was done prior to 1991, but we needed a way to have the government value our services. Each RVU is assigned a CPT code, or a common procedural terminology code. And that's the next step. But so the value of each RVU, so there's a difference, we interchange them a lot, but there's RVU, and then on the physician end, there's the WRVU. So the big RVU would add a prefix is three components. The value of each RVU is three components. So there's the physician work, the practice expenses, and malpractice insurance. And the physician work is divided into four subcomponents. So there's the time to perform, the technical skill / physical effort, the mental effort / judgment, and then the stress on the physician from the risk to the patient that they are assuming. And so, yeah, three components of the big RVU, with the physician work having four further subcomponents. And so each of these three big subcomponents gets its own RVU. And so again, the one we physicians normally care about is the WRVU. And although we usually colloquially just say RVU, but we're not done there. So big RVU is a subcomponent, has three subcomponents, and we care about the WRVU, but then the government tries to factor in the cost of living, because how the value of a good or service or whatnot in San Francisco is very different than the value of a service in rural Montana, let's say. I assume. I actually don't know the cost of living of places off the top of my head, but each of the three subcomponents is multiplied by something called the GPCI, which is a geographic, I can't remember what the thing stands for, but basically it's a geographic conversion factor. And All right, so you take the three subcomponents, you multiply it by the geographic conversion factor based on where you're practicing, and then you take the sum of those products and you multiply, so that some of those products, you multiply that by a conversion amount, it's a dollar amount, and that is where you get the value of each RVU. And that the conversion amount, the dollar amount, is done yearly by Congress, whereas the RVU value comes from a resource-based relative value scale. Those are reviewed periodically by the RUC, which is, I believe, part of the AMA. And so this system, I wrote this down, the system started in 1992. Some other things that I have seen written said 1991, but whatever. The system hasn't been around forever. It's been around for about 30 years now. But that's essentially what we're looking at is every time you go in, so for a consult, how can you even judge the value of a consult? What even is that? If you've seen the different CPT codes, so normally in RADONC, we are dealing with essentially life and death decisions about cancer treatments and the treatments themselves of very high risk. Most of us would bill 99205, which is a complex new consult. And so when you do that, once upon a time, someone had to sit down and say, okay, so someone comes in and has a consult with some version of an oncologist, with a radiation oncologist, and the treatment is essentially life or death. What is the value of that consult? And then, because the corollary to that is, what if you have someone with a cold or really bad allergies, because that's been going around, and they go see a different kind of doctor, PCP or whatnot, and it is a 5-minute consult where it just says, oh, yep, you've got allergies, here's some Claritin or whatnot. So clearly a 5-minute consult for allergies is not the same amount of work or experience, training, whatever. They have different values, but that's a very nebulous thing, right? Like you're placing a value judgment or a value determination on something that has it's a very abstract concept. So how do you do it? So that's where the RUC comes in, and the people on that panel debate it. And it's been refined throughout the years. So currently, going back to 99205, so a complex new consult, the current RVU, or WRVU, is 3.5. So you have basically, we look at 4 different levels that again, going back to radiation oncology, 4 different levels of new consult that we generally deal with. So it's 202, 203, 204, 205 with the prefix 99. And they are rated in order. And so part of this is now, which I absolutely love, is time-based billing and MDM, or medical decision making, which will be a whole other thing. But so the most simple version of a new consult, which by time is 15 to 29 minutes, has a WRVU value of 0.93. Whereas, again, the most complex 99205, which has a time component of 60 to 74 minutes, is 3.5. And so everything has this. So every thing you can bill has a CPT code. And so that CPT code has an RVU unit attached to it. And there is a geographic adjustment and then a dollar conversion amount. And then that is where you get the Medicare reimbursement rates. And then that, we'll go way down that rabbit hole some other time. But that is a fundamental thing of in your day-to-day as a doctor practicing medicine, as an employed, this affects all of us. But as a day-to-day, anything you do in the course of your job in terms of patient on the back end through your medical coders and billers gets assigned CPT codes based on what you enter, what your documentation is. Those CPT codes have RVU values, and there's a technical component and a professional component about the WRVUs. And then that is how everyone gets paid. And then there's different ways that gets divvied up. But so along those lines, everyone kind of talks about how busy you are, how busy a department is, or how busy whatever, when you're evaluating a job to switch or whatnot, or seeing which of you is the busiest when you're having to trying to make your ego feel so good. So anyway, there are a lot of different things out there looking at average RVUs per radiation oncologist. They're all proprietary, so we won't get into that. But basically, for the sake of right now, we're just going to say that the average amount of WRVUs produced per year is about 9,000 per doctor per year. Very variable. And the standard deviation on that is like 4,000-ish, but and depending on what you're looking at, blah, blah, blah. So 9,000, but you can't just say that and have that really mean anything. You're certainly not comparing a radiation oncologist with a pediatrician, with an orthopedic surgeon, because we're all doing different things, and all of our procedures and appointments and skills and expertise is all given a value that's different. And if you're talking to one of your colleagues and practices radiation oncology in Florida, and you practice radiation oncology in Idaho, and you say, well, I do 9,000 RVUs a year, and your colleague says, I also do 9,000 RVUs a year. What does that mean? So I have a breakdown on the slides, which I put on Twitter, is the breakdown of an average RVU sum for a hypofractionated whole breast done in 3D conformal radiotherapy, 15 fractions whole breast. So you generally have a consult, which is 99205. You go on to a three-dimensional complex CT simulation, which is 77290. These are all the CPD codes. A complex plan is 263. And these are all 77 codes. Then you, depending on if you used a breastboard, you generated a 3D plan. If you're doing tangents, that's 77334, but there's two of those because there's two tangents. If you're doing field and you're doing 5 subfields in each tangent, it's 77300 times 10. Then you have a VSIM, and since it's 3D, it's not bundled. And then you will generally do 3 OTVs, which is 77427. It's just a lot of random numbers. You can look on the slide, but that is generally how a single course of radiotherapy for hypofrac whole breast is determined. If you take those CPT codes, multiply them by the appropriate amount, and then sum the products of all those WRVUs, you get an RVU total of 32.2. And so when we talk about all these sort of choosing wisely or financial toxicity, there's a lot of things in the back end that are not really accounted for. So usually those analyses are just talking about sort of technical reimbursement. It's not out-of-pocket cost of the patient. It's not the salary of the doctor, because those things are all, it's really hard to virtually impossible to do that at scale with databases that I know about. But so everything is very different, and doing 15 fractions of whole breast radiation at one site is definitely going to net you different just from the geographic adjustment alone to another site. But your medical coders and billers might choose to do things a different way. There's little hanging points. If you do perfectly parallel opposed tangents and don't modify anything, so don't tweak any MLCs or anything, those count differently than if you have tangents where they're not mirror images. Things like that. There's an infinite number of variations. But if you're getting 32.25 off just a standard hypofrac breast, that's one thing. But you can go through and see, and things like SRS. So SRS has a lot higher RVU value, a lot higher components. So doing 100 patients that are just SRS is going to get you a different amount of RVUs than if you're doing 100 breast patients or 100 something IMRT, 100 head and neck IMRTs. And if you're doing that, as anyone who's listening to this knows, there's a lot more work or changes of doing a right side breast without DIBH or anything, doing 100 right-sided breasts versus doing 100 head and necks versus doing 100 palliative bones. Those are all different levels of work. We're doing 100 lung SBRTs, and the RVUs are not always going to reflect the differences of work. So it's hard to compare, and really it just goes into how difficult it is to really have intelligent conversations about this, or not even intelligent, but to have meaningful conversations about this where your RVU might not be my RVU. And I know it's confusing. I put the slides up, but really, and I see we're coming up on over 20 minutes here. The take home is this, is that RVUs are how we're paid, how things get paid. It's a black box. It's the big RVU is 3 subcomponents. We usually care about the WRVU, and the value of an RVU is set by the RUC committee, and the dollar amount is set by Congress yearly, and all these other things. But that's what it is. So just be very leery and really read contracts thoroughly when you're presented with things about target RVUs and when you're talking about bonuses or this, that, the other thing, but that's what an RVU is. And everything's proprietary. You can pay for it, or you can look around, and there's ways to find this information. But for deciding if a job opportunity is a reasonable sort of deal, if the RVU metrics are in the ballpark of your colleagues, if they're asking for outrageous things, or if the math doesn't add up, it really would behoove you to look at that. But so I hope that's not too confusing. It's easier for me to look at this and think about it in my head than when I say it out loud. It's confusing when it's just straight numbers. So go to my Twitter at Dr. Bekta, and I'll have the slides up, and then I'll eventually get these on Figshare. But that for episode 1 of MBA, Medicine, Business, Anguish, Acumen, whatever you want to call it. And we'll go from there. All right. Thanks, guys. Thanks for listening to this episode of Out of the Basement. You can claim CME for this and any other episode by following the link in the show notes. You can find me on Twitter with @DrBekta, or visit www.bektamd.com. If you like this content, please let us know by rating and following us on Spotify or Apple Podcasts. If there's any topic you want to hear covered, or if you want to come on and talk about something yourself, reach out and let us know, and we will make it happen. Otherwise, talk to you next time.